Dialectical behavior therapy is a comprehensive therapy to improve emotion regulation. For people who struggle with frequent, intense emotions, especially when their emotions create impulsive behaviors with severe consequences. This video guides therapists to help their patients with severe problems with shame, guilt, and self-hatred, focusing on the strategies of exposure therapy, opposite action, and cognitive restructuring. I draw from my 25-year collaboration with Marsha Linehan, the creator of DBT, and also my many years running the DBT Center of San Diego. I hope you find this video useful.
More than other emotions, shame causes intense suffering and self-defeating behaviors. Shame is a normal emotion, and many people feel shame moderately and occasionally. Shame, however, can be debilitating if it is too intense or frequent, when it is in response to personal characteristics that are relatively normal, or to relatively minor mistakes. This problem is called shame-proneness. Just to be clear, we are talking about intense emotional distress combined with strong self-judgment, or a sense of being harshly judged or rejected by others. The person often feels humiliated, disgraced, worthless, or inferior. The person feels unlovable, not just unloved. Sometimes the person has already been severely rejected by their family, spouse, or by large parts of society. Sometimes it is the fear of getting severely rejected or ostracized, sometimes realistic and sometimes not. The person feels strong urges to hide to prevent the expected rejection. Other useful terms are low self-esteem, when this suffering is moderate, and self-hatred, when this suffering is severe. Sometimes people do not use the word shame because they are not clear about the definition, or they avoid it because they feel shame about their shame. The person may use low self-esteem as a euphemism. Shame-proneness is common in social anxiety, major depression, borderline personality disorder, PTSD, and many other disorders. Why do we have shame? Scientists say that shame and guilt are built into our brains, so that we can protect important relationships. They are supposed to motivate people to follow societal norms and avoid wrongdoing. There is not much scientific evidence that shame works like this in modern Western societies, although there is a lot of evidence that guilt can effectively guide behavior. Shame is the most painful emotion, and therefore can be a stronger emotional deterrent for problem behaviors, compared to guilt, but often shame is too strong, and leads the person to be stuck in avoidance rather than working to improve their behaviors. Shame seems to be much more effective in Asian cultures. After transgressions are out in the open, expressions of shame and guilt function to get others to open up to a process of repair and forgiveness rather than getting shunned or disowned. Sometimes the person labels their emotion as guilt, even though shame is a more accurate label. Guilt describes when a person judges their behavior as bad or believe others could reject them for their bad behavior, whereas shame is when a person feels globally bad as a person. I am bad versus what I did was wrong. This diagram shows the difference between shame and guilt, and also two types of shame. Internal shame is the official term for when the person views themselves as immoral, worthless, inferior, unlovable, or otherwise inherently flawed for their behavior or some other personal characteristic. External shame refers to the painful awareness of being judged or rejected by others. A big part of shame work is working on fears of negative evaluation, so there is a lot of similarity with other CBT approaches for social anxiety. This is my favorite patient workbook for social anxiety and fears of negative evaluation. Marsha Linehan's 2015 Skills Training Manual incorrectly says shame is about rejection, but not violations, whereas guilt is about moral violations, but not rejection. This view contradicts shame research, which shows that moral violations can lead to both guilt and shame, but guilt focuses on bad behavior and shame feeling like a bad person. Similarly, threats of rejection can lead to both guilt and shame. This means when you teach patients emotion regulation handout 6, you need to clarify that shame and guilt antecedents are much more similar than what the handouts convey. Both guilt and shame can be triggered by moral violations and rejection. Shame and guilt often go together. It's useful to avoid the idea that the person who is distressed about their problem behavior either feels shame or guilt about it. A person who feels ashamed of their behavior, also feels guilty about what they did, thinking I am bad and my behavior was bad. When they go together like this, shame is often the dominant feeling. People can feel guilt about a behavior without feeling shame if they don't judge themselves globally as a bad person. When people feel shame about physical characteristics that they cannot control, like their height or gender, they don't feel guilty about it. This video will focus on shame because research strongly shows that shame is generally much more maladaptive than guilt. Guilt without shame, often called shame-free guilt, is much easier to resolve. Whenever possible, we try to turn shame into guilt or regret. Before you decide what to do about shame, you have to first decide if the shame fits the facts, or is justified. These are all the ways to ask this question. When the answer is no, the person feels like they have violated their moral values, but they really have not. They feel like they have been severely rejected, but they have not been, and the risk of rejection is actually quite low. They act like their personal characteristics are severely abnormal or repulsive, when in fact they are relatively normal or acceptable. They act like their mistakes are horrible, when in fact they are relatively minor or normal. Unjustified shame is a false alarm. In contrast, justified shame is a true alarm that something is wrong. When shame makes sense because there is a true moral violation or severe risk of rejection. Some big examples of justified shame are when a person has done something truly horrible in the past. Sometimes the person was cruel or abusive or severely harmed another person. Perhaps the person drove intoxicated and accidentally killed someone. In these cases, the main intervention is to make amends for the severe transgression. The most obvious is to apologize and to prevent the behavior from ever happening again. Beyond apologizing, the person can thoroughly hear the victim's pain and express deep empathy for the hurt they caused. Even further would be to make up for the harm as much as possible through good deeds, or even financial compensation. When there is no way to talk to the victim, the only option would be symbolic amends on a bigger scale beyond the victim. For example, if a person had an abortion despite their moral objections, they can't undo that action or make things right with their never-born child, but they could adopt a child as a way to save some other child, or do other charitable acts to encourage other women to make an adoption plan for their baby rather than abort. A war veteran could make amends by donating money to help build an orphanage in the country where he committed war atrocities. When there is justified shame or guilt, do not repeat or reveal behaviors that are deemed immoral or lead to judgment, rejection, or ostracism, because doing so would increase shame. So therapists avoid doing in vivo exposure. The idea is to avoid ruining relationships or otherwise making life objectively worse. When the justified shame is from the person repeatedly harming someone they care about, the main intervention is to stop those hurtful behaviors immediately. Often this ongoing hurt is from the person repeatedly acting angry and mean towards a normal and loving partner, friend, or family member. Sometimes the problem is repeated lying, deception, or stealing. Solving these problem behaviors is the main way to fix the shame problem. In a sense, we are trying to convert shame to guilt by fully acknowledging the severe behaviors to fix, rather than being stuck in self-judgment and hiding. Again, the solution is for the person to repair the behavior and repair the relationship. The person needs to apologize, work really hard to prevent their problem behavior, thoroughly listen and express deep empathy for the hurt they caused, and do as much as possible to make up for the harm. Here is my interpersonal repair handout, and I have my patients follow the interpersonal repair checklist when they actually deliver the repair to the person they harmed. They check off each piece of repair as they complete each part. I also ask the person they harmed to follow along and give feedback about which pieces were done well and which were not. Very often the therapist and the person who is hurt need to guide the person to more effectively empathize or lay out a better action plan for fixing their anger behaviors. It can feel impossible to change the core experience of being a bad or unlovable person at the center of shame, which makes it very easy to hide and ignore the problem in therapy. Therapists need to work hard to counteract this problem-solving paralysis to fully reveal shame and get the patient to do the corrective actions. Shame makes the patient engage in many therapy-interfering behaviors. The main problem is severely avoiding talking to their therapist about shame topics, or avoiding the therapy tasks that could improve their shame and their life, because it's too uncomfortable to talk about their shame. The therapist has to be on the lookout for shame, even when the patient does not verbalize it, and be flexible and creative to get the patient to engage with this uncomfortable work. Here is the full set of DBT strategies for justified shame and guilt. The main focus is always to fix behaviors and relationships. In addition, it's often helpful to do a variety of things to help the patient better tolerate their mistakes or rejection, for example, by addressing their thoughts that exaggerate the transgression, judgment, and rejection. One way is to teach the patient to be mindful of their shame thinking, sticking to the facts, and seeing their judgments as thoughts rather than facts. Another way is to do cognitive restructuring, and have the patient check the facts about the true severity of what they did, and how others have, or will, react. Therapists also need to help the patient use self-validation to develop self-compassion. Therapists can help the patient find ways to not view their shame problems as catastrophes, by talking through how the patient can recover from the damage created by their behaviors, or how to mitigate the problems from people not liking some part of who they are. By fully acknowledging shameful events in therapy, the shame can soften and instead become guilt, regret, or disappointment. Repeatedly and thoroughly talking about the shame topics helps the patient desensitize to their shame-eliciting thoughts. When the patient sees the therapist show compassion rather than judgment, they learn that not everybody will judge or reject them. This is a form of in vivo exposure. Sometimes it is confusing to know if a shame-eliciting behavior is justified or unjustified, meaning whether it should be avoided or not. Is it ever useful to repeat or reveal behaviors that lead to judgment or rejection? Sometimes it is very useful to tolerate judgment or rejection when the behaviors help create opportunities that match our values. We may decide to live with the discomfort of being moderately judged for our appearance or our sexual orientation because it alleviates the burden of isolating or hiding who we are. We go on dates and job interviews with a high chance of rejection, but with the hope of eventually succeeding. To be true to our values, we may decide it is worth it to openly take a stand on important political issues and accept the hatred that comes. Social disapproval is on a continuum and sometimes does not truly make life worse. Each person has to evaluate their own pros and cons for these sometimes tricky decisions. Now let's turn to what to do when the patient struggles with unjustified shame. It does not fit the facts. This is when there is truly little or no risk of rejection, and their behavior does not violate morals. Sometimes it means they unfairly blame themselves for something bad that happened. At the start of therapy, patients usually act as if all their shame is justified, and the therapist's main job is to shift that view. They underestimate how normal they are. They overestimate judgment and rejection. They have excessive self-judgments. These are all thoughts, but they see them as facts. Common areas of shame are around sexual feelings and behaviors, such as masturbation, homosexuality, and kink. Feeling excessive shame when getting feedback about their behaviors. Sometimes when focusing on their face or other specific parts of their body. Therefore, they avoid tight clothing, swimsuits, and looking in mirrors. They don't let their partner see their naked body. They avoid getting feedback from others. They keep unnecessary secrets, for example, about mistakes, masturbation, being gay, binge eating, or pieces of their history like having been sexually abused. They do not act assertive because they feel unworthy. We need to be very clear that these avoidance behaviors are caused by shame, and they also create the shame. In DBT, the main intervention for all unjustified emotions is exposure therapy and opposite action. It's based on the idea that the internal experience of emotion causes emotion behaviors, and also that emotion behaviors influence internal emotional experiences. We act how we feel, and we feel how we act. Depressed feelings make people isolate, avoid, and give up, and it's also true that these behaviors make them feel even more depressed, overall. When a person has an anxiety disorder, they excessively avoid many things they fear, and those avoidance behaviors keep their fears intact. Excessive avoidance maintains the need to avoid. When a person has an anger problem, physically destroying things and screaming makes their anger problem worse. When a person with excessive shame punishes themselves, their self-hatred problem increases further. Essentially, the person has an abundance of practice acting depressed, acting fearful, hating themselves, or acting angry, and so those reactions become even stronger in the future, even if in the short term those emotional behaviors bring some sense of relief. What this also means is that when you're depressed, acting like a non-depressed person helps reduce depression, eventually. When you're excessively afraid of things, consistently approaching what you feel like avoiding will reduce your fear. Acting kind, gentle, and empathetic towards a person will reduce your anger. Acting confident will increase your feelings of confidence. Research shows that behavior change is one of the most powerful ways to improve how we think and feel, when our emotional reactions do not fit the situation, are excessive, or are not effective. When that's true, the first step is to be with the emotion trigger. Either it occurred on its own, or the patient or therapist can decide to face a trigger right now for practice. For example, they can do things that elicit shame or go into a situation that evokes the unjustified shame. Next, the person uses skills to not act on their emotions and urges. Next, they activate opposite behaviors. When we go through this process, our emotions improve because we desensitize to our triggers, which we call exposure therapy. Exposure is one of our most powerful strategies for reducing the power of emotion triggers. This is the emotion regulation diagram from the skills manual. You can see how the top X shows how exposure and opposite action require the person to not act on their emotions, and improves their ability to not act on their emotions. The lower X on the left shows how a person becomes less reactive to emotion triggers after doing a lot of exposure and opposite action. What this means is that the person would share their secrets with supportive people. They would tell their partner when they make mistakes or binge eat, that they masturbate, and that they were sexually abused. They would tell friends and family that they are gay and go to the gay pride parade, and they would talk about their family and their history, for example, poverty or mental illness. Rather than reacting to feedback by getting defensive or distracting from it, they would ask for feedback, ask the person to elaborate fully, and then summarize it all. This would mean thoroughly discussing their small ineffective behaviors, such as broken promises or other ways they bothered or inconvenienced the other person. They would treat themselves to their favorite foods and activities when feeling unworthy, rather than denying themselves. They would ask for favors when feeling unworthy, rather than avoid being assertive. Rather than punishing themselves for mistakes, they would validate themselves after a mistake, or when feeling self-punishment urges, and they would treat themselves to favorite food and activities after a mistake, or whenever they feel self-punishment urges. Rather than not letting others see their face or body, they would go without makeup, or use a lot less of it, wear tight clothing or swimsuits in public, let their partner see their naked body, shower at the gym, or go to a nudist colony. Like this guy who is working on his body shame. It is common that people avoid their shame by getting angry. They may have felt shame because they were too sensitive about a comment about their physical appearance, and then feel even more shame when they feel ashamed of their angry reaction to that comment. Anger can create a major distraction to divert attention away from shame thoughts and feelings, sometimes by getting other people to stop doing or saying the things that trigger the shame. The main intervention for this is to repeatedly go back to the shame triggers that led to anger until the person can correct those shame triggers or better tolerate them. In addition, the person may need to do an interpersonal repair for their justified shame about getting too angry. Look for shame in sessions. Patients often have behaviors in session that divert attention away from shame thoughts and feelings, sometimes by getting the therapist to stop talking about things that are triggering shame. Anger in a therapy session is an obvious example of this kind of avoidance. Less obvious are behaviors like verbose or tangential conversations. Sometimes patients with body shame hold objects, like pillows, in front of them in therapy sessions so the therapist cannot see their body, and when that happens the therapist needs to ask them to remove objects so their body is more visible in the session. Again, the main intervention is to repeatedly go back to the shame triggers in sessions until the person can better tolerate them. Let's briefly review how to teach this opposite action skill to patients when their shame and guilt do not fit the facts. The main problem teaching this skill is that the opposite action handouts in the skills manual are too confusing. It is Emotion Regulation Handout 11. Here is my revised handout that I give to patients that I believe is much more clear. As you can see, it combines shame and guilt because the process of identifying opposite action options is the same for shame and guilt according to emotion research. For both, opposite action is based on verifying the facts about moral violations and rejection. This shows what is effective for justified shame and guilt. It's even more complicated to decide what to do when shame or guilt is a true problem in one way, but not in the other. This handout shows what to do when there is a moral violation, but not rejection. In the bottom section, it shows what to do when there is rejection, but not a moral violation. We've already reviewed opposite action, which includes in vivo exposure to current triggers, and what Albert Ellis calls shame-attacking exercises. Our other main exposure strategy is imagery exposure. We have patients repeatedly vividly imagine their shame catastrophes' worst-case scenarios, and also memories of traumatic shaming events. Similarly, we have patients repeat shame-eliciting statements to get them better able to tolerate thinking about their behaviors and personal characteristics. In addition, we use mindfulness of shame thinking, checking the facts, and cognitive restructuring, just like we talked about previously. Our main strategy for thorough cognitive restructuring is called rational emotional role play. The most common reason the patient does not improve enough is when the therapist relies too much on insight and self-talk. Often when this happens, there has not been enough exposure, the exposures have not been focused on the most central areas of shame, or the exposure has not utilized imagery of the shame catastrophes, from the downward arrow. Another problem is when the therapist has not corrected the distorted thinking enough, which could be due to not fully discovering the distortions or the challenges have not been compelling enough, or the patient simply has not practiced challenging their shame thoughts enough, or the therapist has not made the practice relevant enough or challenging enough. Often, it means it was lacking decatastrophizing how to survive severe rejection if it occurs. Another issue is when there are just too many shame-driven behaviors, especially if there is a lot more avoidance than opposite action. Sometimes there is not enough progress because some important shame topics have not been discovered. The shame checklist is a very useful screening process to prevent this. It is a comprehensive list of shame triggers, and sometimes patients will mark their areas of shame on a form like this even when they avoid telling their therapist directly. There are several ways to help patients identify their shame thoughts. Standard self-monitoring and the downward arrow technique are very useful. It is also useful to ask them what they are thinking when you have them do something to elicit their shame, like talk about painful details of their shame topic or imagine a shameful situation. Validation is useful to counteract the self-judgment and self-blame at the center of shame. Therapists communicate to the patient how they are much more normal than they acknowledge, so that the patient can then validate themselves. Sometimes it is a compelling and compassionate explanation for their dysfunctional behaviors, making it very clear that moral values were not violated, and that most people who matter accept them for who they are and already forgive them for those behaviors, or they will be forgiven after the repair is completed. Rational emotional role play is a very useful way to get patients to practice self-validation, self-acceptance, and self-compassion, and to make the practice highly relevant and challenging enough to have a large and lasting impact. It is important to thoroughly prepare the patient, by thoroughly explaining the process, and getting the patient's commitment. Make sure the patient understands that the goal of the practice is to increase cognitive flexibility, not to get rid of shame thoughts, or to prove that they are wrong. Rather, the idea is for you to show them more thoughtful and effective responses to their shame-driven thoughts. Then you show them, and then they practice. Here are some important details for the two most important parts, phases 1 and 2. In phase 1, the therapist thoroughly shows rational and validating ways to respond to the shame thoughts, making it very clear that they are normal, moral values were not violated, and that most people who matter accept them for who they are and accept their behaviors. The therapist can also explain how others will accept them if they stop avoiding and hiding so much, and can also talk through acceptance and compassion. Instruct the patient to spew their shame thinking, and to try to thoroughly discredit what the therapist says. Say to the patient, "Don't agree with me, just keep arguing with me, and let out everything that you feel supports your shame." This gives the therapist a full chance to assess the intricate web of negative thoughts behind the shame, and show the patient effective responses for each one. Then they switch roles for phase 2. Now the patient rehearses validation when the therapist plays devil's advocate, saying out loud invalidation, including exaggerations about rejection and moral violations. This can sometimes be a really emotionally intense role play, so it is sometimes best for the therapist to ease into this, starting with a bland voice tone and bland rehearsal, prompting the client by saying things like, "When your brain says everybody thinks you're a horrible person, then what should you say?" When the patient slips out of role and starts agreeing with or offering support for the shame thoughts, the therapist needs to remind the patient to counter the shame thoughts and say, "Don't agree with me, repeat back the validation, acceptance, and compassion I told you earlier." If the patient forgets the validation, you can offer brief hints, or have them write down the main validation points, and then read off their notes when they practice. It is important to have patients self-validate with confident, non-ashamed body language and voice tone to normalize their thoughts and feelings. A patient with severe shame often needs many sessions with this thorough phase 2 practice, at least 10 minutes each time. They need to be able to generate these useful responses without their notes or therapist reminders, and with intense emotion. The patient will make the most progress if the therapist eventually increases the difficulty of the self-validation practice by making the devil's advocate comments more judgmental and mean, including voice tone. Make sure the patient is ready and first agrees to increasing the challenge. It also helps to have the patient listen to recordings of the role play between sessions to help them remember it, and to identify any lingering negative thoughts which need to be worked through. It can also help to have the patient write out a full self-validation essay on the most difficult shame topics, which can be easier to review during shame episodes. Rational emotional role play is also helpful for justified shame, to help the patient develop hope, self-acceptance, and self-compassion. This happens when they thoroughly articulate how they can repair their behavior, get compassion and forgiveness from others, and develop a meaningful life despite all the problems they have faced. Again, the goal of rational emotional role play is increased cognitive flexibility, not to win a debate or convince the patient your views are correct. When patients say they don't believe the validation, encourage them to continue by saying, "That doesn't matter. Just keep going. Our goal is that these thoughts not control you, and that you suffer less." The negative thoughts may not change at all, or only change after much practice. Cognitive flexibility is a major way to decrease the suffering caused by shame proneness. Other ways to increase cognitive flexibility include asking patients to check the facts immediately after reacting. This may include asking rather than relying on assumptions, having the patient take a poll of others' interpretations, and doing some research. For example, a patient who has unjustified shame over their physical appearance could directly ask someone their thoughts about the patient's appearance when they perceive they are being judged negatively. They could poll trusted friends and family members regarding their thoughts about the patient's appearance. They could look at pictures of others' varying physical appearances, noticing the wide range of looks, or even consult plastic surgeons for their opinions and research the risks of surgical intervention. An effective way to change shame proneness is for the patient to frequently practice skillful responses during naturally occurring shame episodes, ideally, soon after they start. I call this skill the 5 A's because the name of each P starts with the letter A. We already reviewed these skills for unjustified shame, and this acronym is just a convenient way for patients to be ready to thoroughly and effectively respond to their shame, right as it occurs. First, the patient uses mindfulness skills to become fully aware of their shame thoughts and feelings, and gain some psychological distance. For example, they could say, "I am having a self-judgment and making assumptions that others are thinking horrible things about me. Those are thoughts, not facts. I can't read minds. I heard my mind say, 'Nobody likes me,' which is also an all or nothing thought." Next, the patient attributes the reaction to their brain's sensitivity or their upbringing. For example, "My mind is making all this up because my dad's verbal abuse is still stuck in my head." My unjustified shame reaction right now is my trauma memory and nothing more. Next, the patient allows and accepts the thoughts and feelings, and does urge surfing, to avoid fighting with their reactions, which would only keep them stuck in their shame. Next, the patient articulates alternatives to their shame thoughts, drawing from the rational emotional role-play cognitive flexibility practices they did with their therapist. For this part to be effective, the patient usually needs to read their notes from their session, or listen to an audio recording of their therapist challenging these shame thoughts. I tell my patients to immediately articulate the validation and other alternative thoughts out loud, either to their partner or to me. I sometimes tell them to spend a minute practicing with me in a phone call, or to leave me a phone message, so I can verify how well they responded flexibly to their shame thoughts. Lastly, the patient needs to find a way to act opposite to their shame thoughts and feelings, which usually means doing opposite to shame behaviors that they already discussed with their therapist. This skill is important to emphasize the value of immediately and consistently practicing mindfulness, cognitive flexibility, and opposite action soon after shame gets triggered. Just practicing these skills in general, when they are much